data a little bit more and throw in a few other types of ways to pick patients. Okay, so there's lots of ways we can talk about selecting patients for immunotherapy, and right now, most pertinently, second line. There's a variety of clinical parameters, I think, both positive and negative. It'd be really interesting to see the impact of performance status on outcome, because now these therapies are very well tolerated. This could well be something patients are given on their way to hospice just to see if they respond. And we have virtually no data on performance status impact on immune therapy, so you might expect there to be one. And then there are multiple things that the pathologist can tell us that might impact on benefit of immunotherapy. So I'm going to touch on the second line data results. This is I'm going to start with the non-squamous trial. This is second line non-squamous randomized to chemo versus Nivo. And we all know these data. There was a survival benefit in the Nivo versus Dosi. And if you look at the breakdown of the parameters associated with benefit, I'd like to point out that there was no benefit in never smokers, statistical benefit, and it was all in current former smokers, and in EGFR mutation positive patients here, there was also no benefit in this non-squamous trial. Age didn't seem to make a huge impact, though it seemed to be a little bit less active in the oldest patients. If you look at the objective response rates, actually the response rates were almost the same, or not that much different, but it was really the duration of response that drove that curve. And if you look at PD-L1 expression in this population, you can see that with any of the cutoffs they used, 1%, 5%, or 10%, there was a very convincing curve in overall survival improvement for 1, 5, or 10% cutoffs. And if you look at the less than 1, less than 5, or less than 10% cutoffs, really there was no convincing benefit. So this is kind of what you'd expect, that there was a strong dependence on PD-L1 expression and a PD-1 pathway inhibitor. And if you look at the forest plot here, I think, you can see that the negative PD-L1 status in both PFS and OS really had a hazard ratio of around 1 or even slightly less than 1 for PFS. And it's interesting, though, it really is equivalence for Nivo versus Dosi in the low PD-L1 patients. It doesn't seem like it's worse. And then the toxicity profile really favors Nivo, which led Roy to recommend giving even this group Nivo, and that's what the FDA label says. This is again, the interaction now not with survival but response. And you can see that the response rate is always higher in the positive, greater than 5%, less than 5%, greater than 10%, less than 10%, statistically significant p-value. But interestingly, in these, say this one, less than 1%, the Dosi had almost twice the response rate of Nivo. And the docetaxel response rate really was pretty much independent of PD-L1, as you might expect. So now let's talk about the squamous situation, which by the survival curve looks pretty similar, maybe a little better. Here, if you look at PD-L1, the impact of PD-L1 expression on survival in squamous non-small cell second line therapy, it's a total washout. There's absolutely, really, every subset, every group had pretty much the same hazard ratio. Now let's just talk. So that leads to the question: are the selection factors intrinsically different between squamous and non-squamous? I'll just mention the data that's available in Pembro. Now, this is again, let's see, is Pembro the same as Nivo? Never smokers have half the response rate of current former smokers. Adeno's similar, but a little less than, and probably attributable to this. If you look at the effect of mutations, the response rate is again half in EGFR mutated. It's lower in ALK positive, maybe a little higher in KRAS, also probably just reflecting other smoking history, for example. So you look at, though, at PD-L1 and survival, this is a mixed population where clearly with Pembro, some of these are previously treated, some of them aren't. In all patients, this proportions, they use this stupid nomenclature of PS. It's actually proportion score, not performance status. But the PS, with a high level of PD-L1, clearly survival was better than with lower levels. And again, if you look at the response rate, the patients with the highest level, the greater than 50% PD-L1 expression, had the greatest response rates. Those with the intermediate had the lesser, and those with lower had less. So that's Pembro. What's the data from Atezo? This is just one slide I found for Atezo. Again, smoking status, less than half the response for never smokers, less response for EGFR mutant, and in this study, less response for KRAS mutant. So these are all factors that we can use to help select patients for this class of agents. But the fact is that 10% response rate is about what you get with docetaxel, and response rate is not associated in these studies is fine, but it's duration of response that really drives the survival. So just touching on first-line therapy, I know we're going to talk more about this, but the fact is that really the response rates for, this is the high PD-L1 expressors and the low PD-L1 expressors, there is a little bit of, in the combo studies, showing it suggests that there's an improvement in the PD-L1 positive patients in first line. And again, this is first line, and but you look at, there are quite a few patients in this low PD-L1 category that are objective responders. So again, even this less than 1% cutoff, you're still getting patients that respond. In small cell, I showed the data yesterday. There seems to be really no effect of PD-L1. Some of the best responders are the ones with the low PD-L1. And so this is all complicated, and I'm sure Fred's going to talk about this, the differences in the different companies' tests and the different cutoffs and the different way they look at things. Fred will talk about that in detail. And the complexity of the immune response is really not reflected in the PD-L1 status alone. There are other types of immunologic immune cells in the environment that obviously make a difference. The mutations in beta-2 or TAP or MHC in these tumors also make a difference, and we're ignoring those in these biomarkers. And I'm sure Fred is going to talk about this as well, but there's a lot of limitations to an IHC biomarker. It's dynamic, it's heterogeneous. The cutoffs are unclear. It's clear that there must be an importance of an interaction of multiple immune parameters that is mostly being ignored by most of the assays. Sampling, tissue timing, etc. There's a lot of, this is clearly a suboptimal biomarker. I just have one slide on a very nice recent study by Nair Rizvi, published in Science, talking about mutation burden. So what he did is he made up his own clinical parameters called durable clinical benefit and no durable benefit. It's amazing they accepted that as a clinical endpoint. But basically, mutation burden was associated with durable, high mutation burden was associated with durable clinical benefit, improved durable benefit. Patients with high numbers of transversions, the types of mutations you see with cigarette smoking, did better. So again, this is a surrogate of cigarette smoking. And that when they looked at specific mutated epitope T cells in these patients, there was a rise in this, the specific mutant-specific T cells that corresponded to the tumor response in these patients. And so this is yet another potential way to select patients. But again, it's all confounded with smoking, which is much easier to measure than mutation burden. Or at least, anyway, I won't go there. So, so the bottom line is we don't have a robust biomarker yet. IHC, however defined, really does, in virtually every case, enrich for clinical benefit, except in squamous and in a small cell. And so squamous and small cell may need to be viewed differently. In clinical practice, however, we've developed the word nivolumab to be used as a verb in our clinic. You nivo people today, and you just nivo everybody, basically. If they have a vein, they can get nivo. So I think we're in desperate need of really good biomarkers to help protect our health care costs. Smokers and high mutation burden patients respond better. Clearly, very universally in all of these studies, EGFR mutant patients have a lower response rate. And then I talked about PD-L1 is maybe different in squamous and small cell or with Ipi-Nivo combinations, but responses are still observed in low PD-L1 patients. Any questions?
Dave, nicely done. You know, I think the nivolumab data is a little misleading. You know, when they present the data for greater than 1, greater than 5, greater than 10% positivity in the survival benefit in the non-squamous, that's true, but it's driven by the higher expressors, right?
Well, of course, that's why the cutoffs don't make much of a difference.
Because when you look at 10% or less, there's no benefit, right? So it really doesn't mean if you have a 5%
so it's meaningless. All those the threat. So the cutoff is not very sensitive.
So they probably, if they did a 50% cutoff, like
Pembro did, they'd see most of that same effect. Correct.
And so I think the important point might be in selecting towards chemotherapy in the low expressors, a patient's very symptomatic. It looks like response rates are higher with chemo than not. Now, people don't want to use chemo if they don't have to. I understand that, but there may be patients who really should get chemo before.
Well, that's being tested in the first-line trials. So there's for example, the BMS first-line trial has a 1% cutoff for eligibility, but it's powered on the high expressors, and it's randomized between Nivo and chemo, and I think the outcome of that study will be really interesting. I hope it's positive in the high expressors.
So, any evidence that the duration of response varies by the expressors? So in other words, okay, you may have responses or even stable disease, but is there any?
Well, that's what I was kind of implying, that the response rates are not that impressive, but it's the duration of response that drives survival, and the survival is also correlated with PD-L1 status. So I think the duration of response clearly is related.
So it can be better. So in that respect, if you're treating somebody, let's say a non-smoker, or somebody who you may say is a less chance, do you watch them a little different in terms of how you're going to manage that patient on Nivo? So say, look, I don't see I'm seeing something at an early point. I might as well get on to another therapy. Or is
we watch all these patients. I watch them very closely, and we manage it, every week. Every
so you
time
won't
we see them.
Switch quicker on some of the patients that you're not as excited about versus one that you say, hey, this should be.
If someone has no tumor growth and is feeling fine, I won't switch them, because there's not that many good options in these patients.
So as they say, it takes two to tango. So PD-L1 is only important if there's PD-1.
Yeah,
so
of
has there
course.
any
And you-
consideration been given in clinical trial to looking at the ratio of PD-1 to PD-L1?
Right. So in our neoadjuvant trial, for example, we're doing immunophenotyping for 150 different markers in the tumor, in draining lymph nodes, in peripheral blood. We're looking at circulating exosomal RNA and microRNAs. We are trying to be very comprehensive, and we'll have pre and post tissue and blood samples on these patients, as well as whole exome sequencing. I think that will be an incredible, and clinical and pathologic, radiographic and pathologic tumor responses in that same set. So that'll be a very rich data set to study for the kinds of questions you're talking about. Of course, you need the receptor to have. It's like, treating a patient with beta-2 mutations or TAP1 mutations or with these T-cell promoting therapies doesn't make sense.
Great talk. My question is related to Dr. Crawford's question, which is looking at the CheckMate 057 result by PD-L1 expression in those subset analyses. It actually looked like the patients under 10% had worse survival initially. The curves crossed. The Kaplan-Meier curves crossed at like 9 months, suggesting that there may be patients that are actually being harmed by being given Nivo instead of chemo. So do you think that's a real observation, that in addition to looking for looking for marker to identify response, do we need to think of identifying a marker that helps us select, to make sure we don't harm patients potentially?
Yeah. So these studies were not that big. There's a lot of kind of line wobbling that happens in a few hundred patient studies, but there's always a possibility of harm that happens in these early days of immunotherapy, and I think that's a reasonable question to ask. Okay, we're